Welcome, everyone. We'll wait just a bit to let everyone join, and then we'll begin. All right, let's get started. Welcome to the Healthcare Lounge. Today's topic is medical utilization management. And now I will turn it over to Nelson.
Thank you, Kendall. It is great to have you here with us in the Healthcare Lounge. I happen to be in Orlando today for the rest of the week. The National Speakers Association is having its annual conference, and so I am here for that. But right now, I am here with you in the Healthcare Lounge, and it is my pleasure to introduce a dear friend, a massive figure in the healthcare industry at large, but our piece of the healthcare industry where we are changing the status quo. And this individual actually played a huge role in the birth of what we now know as next gen benefits. When I met her in 2016, I'll tell that story in just a moment, but let me introduce you to Deb Alt, registered nurse with her master's in business, and she is founder and president of Alt International Medical Management, which is the industry's leading medical utilization management firm. There is a lot to tell you about Deb, so let me just share some of her accomplishments and recognitions. Deb and her husband, Chris, who run AIM together, were recognized by Healthcare Insights magazine. Was this in 21 or 22, Deb?
Yeah,
just a couple of years ago, as one of the healthcare power couples, which was fantastic to see them on the cover of that magazine. She has won numerous awards. In fact, just recently when we were in DC, Deb, for the Healthcare Innovation Congress, the Validation Institute presented AIM with another award for medical management, top medical management firm. You received the most valuable health plan partner at the U Summit Symposium last year, and have received the Innovation Award at Send from Next Gen Benefits. And then you have either authored or been mentioned in Healthcare Manifesto, Readmission Penalty, where you're one of the contributors. Not Rocket Surgery, Life and Death Decisions, the C-Suite. You and Aaron, your son Aaron, who's CFO at AIM, were co-authors. And AIM is a certified next-gen benefit solution provider. So lots to talk about what you've achieved and accomplished. But what I'd like to do now is bring you on stage. There you go. And let's have a conversation about medical utilization management, which until 2017 or 2018 was just medical management. But I want to go back to 2016 when you and I met, and we had a conversation. And I asked you, what exactly does AIM do? And at the time, I was running the Mastermind Partnership, which at the time was called the Agency Growth Mastermind Partnership. And you looked at me and said, well, we improve the quality of healthcare and lower the cost. And I hesitated for a minute. I said, wait a minute, claim is a claim is a claim is what's going through my head. I said, what? You can't do that. I presumptively said to you. And your comment to me was you kind of arched your eyebrows, smiled, stepped back and said, I never got that memo. And that was our introduction, my introduction, and our mastermind partner's introduction to managing the cost of care, managing the supply chain of healthcare. And that conversation led to us introducing cost containment strategies, along with an emphasis on self-funding. Managing the supply chain of healthcare became a concept that we embraced. And now we have a full-fledged movement. But in many ways, not in many ways, in that one conversation, that was the birth of this movement, because you introduced me the fact that, oh yeah, we can manage the quality and cost of healthcare. Let me talk to me about how you evolved into this, because you started out just as a traditional medical management firm, managing difficult patient cases, doing some pre-auth, et cetera. But you didn't start off managing the supply chain of healthcare. So how did you evolve into that?
Yeah, really at the behest of some really savvy self-funded employers. So the genesis of AIM, I went to a handful of people that had been self-funded since the 70s, right? And they were employers. And I had been in the TPA world, and I said to them, listen, we believe the same things. We're at all the same conferences. Why have you never become a customer of any of these TPAs that I've been part of the medical management for? And every one of them gave me some version of the same story. It was, you come in here with product red, white, blue, and we know our people, and we're self-funded because we want fuchsia or purple or, magenta. And so it became apparent that the existing kind of programs, the traditional programs, were not sophisticated enough for those buyers who understood self-funding and who wanted customized solutions. So we, as a company, entered into the market at the behest of groups who wanted customized solutions. Now, little did we know that a lot of the technology and software and things had to be built to support being able to do that, let alone to scale doing that. But that's really kind of the genesis of it. Employers have always wanted to take really great care of their employees and to not get price gouged in the process. And the beauty of the fee-for-service healthcare system is higher quality healthcare is inevitably lower cost. So it's a natural synergy, right? But that's kind of how it came about.
Well, I want to explore that extremely counterintuitive idea that there is an inverse relationship between cost and quality in healthcare. But before I do that, let's talk about quality first. And let's talk about quality first. You have hammered home to me and to the advisors in the mastermind, the advisors who have come to Ascend every year, the Ascend conference, that it is a mistake for lots of reasons to talk about reducing the cost of care without talking about improving or at least maintaining the quality of care first. So do you want to explain that? And actually that does get into the inverse relationship a little bit, but why are you so adamant about emphasizing quality first?
Yep. So I always talk about you should never divorce quality and cost. They must always be discussed and travel together, so to speak, in any conversation that you're having with a patient or with an employer. The fact of the matter is, the higher the quality of healthcare, the faster someone recovers, the better their recuperation, the fewer the complications, the fewer problems that they experience in getting as healthy as possible, the cheaper that care will be, because the US healthcare system is built on fee-for-service, right? It's kind of the old Jiffy Lube approach. You take your car in to get the oil change. There's a reason they check your wipers and your blinkers while you're there, because it's fee-for-service and they get paid more if they address those things as well. I, as a healthcare practitioner, know that the hands-on bedside practitioners would never in a million years provide mediocre healthcare, or what I call just good enough healthcare, for the purpose of price gouging or increasing the payments that they get. But the fact of the matter is, every practitioner of healthcare is a human being, and they all have different skill sets. They all have different levels of expertise. They have access to different kinds of equipment, depending on which OR they're working in. All of those things have a bearing on how quickly a patient can recover, the likelihood of them having a complication, right? So the challenge has been, traditionally, 20 plus years ago when we started doing this, there were not strong objective quality scores or measures. Back then there was merit to, well, hey, I'm a doctor in the inner city and we only get the sickest of the sick, or I'm at a level 1 trauma center, so of course more of my patients die. But we know mathematically that you can case mix adjust, severity risk index. There are ways to level the playing field, and those have now been applied to medical data. So that argument no longer holds a whole lot of water when you're trying to look at quality. The primary challenges on quality right now is there's not a single Consumer Reports of Healthcare yet. We're working on that, right? Because if you want to have a tonsillectomy, you're probably looking at a different database than if you're trying to help somebody through addiction recovery, and a different database if it's about imaging, and a different, so there's not a single place, there's not a single conduit for patients to access that information. We license that information from all the different entities and, go through a whole vetting process to look at the quality of how they're doing their mathematical algorithms, et cetera. The other challenge is patients have not yet been exposed enough to the idea of disparities in quality. And so I once got fired from a case because an executive's family member who was on the plan said my mama went to him and my grandmama went to him and they both did just fine, but his quality score was horrible. And so when we tried to kind of steer her away from that surgeon to another, she wasn't open and receptive to it because he's a nice guy, right? She had a horrible outcome, by the way, cost plan over $200,000. So her mama and her grandma had great luck. She did not. And I'm like, we tried to wave her off, right? We could have seen that coming. We saw in the data. The other challenge is healthcare is a highly emotional issue. And we're trying to interject science and math and logic into something that is even chemically difficult for a sick person's brain to comprehend, right? So I have told the story numerous times about when my mom did the Nestea plunge on the hardwood floor in my dining room, and I, Nurse Deb, forgot to call in and ask, what's the quality score of this surgeon? The ER is saying she has to go to the ER, she has to go right now, things are not looking good, she may not survive the surgery. You're just not physically capable of making logical, well thought out decisions at that point in time. Every patient deserves to have an advocate come alongside them. Unfortunately, we do still experience patients who, it's almost like when people are addicts, you can only help the ones that are open and receptive to being helped. You can't help everybody because some people just aren't open and receptive to it. And I think it's because they haven't been exposed at a non-emotional time to the fact that you can even access quality data.
I found an article in a peer-reviewed medical journal doing some research, and the title of the article was 50% of all doctors are below average. Now, first of all, that's tautological. Of course they are. Second, it was said with some levity, but the research was about, well, what do we do about the 50% of doctors who are below average? Because if people knew that, nobody would want to go to them. So how do we raise their skill set and outcomes? But the fact is, what do you call the at West Point, the cadet that who graduates last in his class is called the GOAT. Do you know what they call the medical student who graduates last in his class at Harvard Medical School? Sure you do.
Doctor.
It's doctor. Doctor. And that doesn't necessarily mean he or she will be a bad doctor, but odds are good they're not going to be a great doctor because they obviously didn't do that well in school. But the fact is, we do have reliable quality data. You said earlier a moment ago that you think patients, consumers don't have enough information. They don't have any information, Deb. They do not know that there is reliable, quantifiable, objective data, by the way, based on data reported to the Centers for Medicare and Medicaid by the doctors themselves. So if the doctors don't like their scores, they should look at their outcomes because it's based on the scores that they submit or the outcome data they submit to CMS. All right, so quality, we lead with quality. And I asked you at one point, so where do you find the price data that you use to guide your patients? And you had a surprising answer for me. We don't. We don't look at price. We just look at quality because low price, or not necessarily low price for the procedure, it might be the most expensive surgeon in the country, but his outcomes are going to be so much better that there are no complications. And let's remember who pays for the follow-up surgery and the readmission, hospital readmission when there is a complication. It's the employer that pays for that. So it's incredibly important to mitigate and eliminate whenever possible those complications. So
Now, I would say,
Deb,
I'd add to that, though, that was true then. It's true to some extent now. However, innovative brokers and consultants across the country are helping innovative employers do unique things like establish direct contracts, right? You've got bundled surgical pricing, you've got carve-out imaging, you've got durable medical equipment. So to some extent, as long as quality is equal or greater, then that's great. We will take that direct contract or that pricing component into consideration when the quality field is level. That's just part of the growth of the model. But what we will not do is compromise quality just to get price. That's not an HMO, right? So if the ear, nose, and throat doc who's in the middle of Missouri really has a horrible quality score, it doesn't matter to me as a nurse or as someone who's a de facto plan fiduciary for the self-funded plan sponsor that we've got a better price from a quack. That's not doing anybody any good, right? So as consultants start to do those, I would strongly encourage them, be cautious, because we've seen some really low quality facilities offer really great discounts. But it's like, okay, you're only going to charge 108% of Medicare, but you're going to do 10 times more procedures or services because the quality stinks. You're going to have all these complications to treat. So people need to be kind of wary and cautious of that. In reality, if you get the right patient into the right care, evidence-based clinical care guidelines at the right time, overcoming all those access issues in the right place, the majority of the time, right price will be the natural consequence, with the exceptions being buy and bill drugs, especially chemotherapy, prosthetics, where they're buying it, they're marking that price up so egregiously that no discount on the planet will get it to where it should be, right? Or where there's an alternative way outside of the health plan, like a clinical trial or a MAP or a PAP, or, where there's some alternate founding way to pay for that health care that patient would be eligible for. Grants, foundations, we've got people doing all kinds of creative things to help people afford the health care that they actually need.
our friend Leah Bender, who runs the Leapfrog Group in Washington, I think she actually first said it on the stage at Ascend, there is no good price for bad healthcare.
Right.
And again, it's tautological. Of course there's not, right? Who cares if it's cheap, if it's bad? You might buy a cheap car knowing it's bad because it's really cheap and that's all you can afford, but nobody wants bad healthcare.
Right.
So that's sort of the statement that underlines the point that you just made. is we've got to be careful when we've got to be careful when it's all about price. You and I both co-authored the book Life and Death Decisions in the C-Suite. And that title actually came from a presentation you gave at one of our mastermind summits a couple of years ago, where from the stage you said, look, this is not an insurance decision. This isn't a business decision. These are life and death decisions that employers in the C-suite, HR in the HR department, as well as the advisor and the TPA and any other stakeholder that has any say in who a patient ends up going to see, is culpable when the patient is forced into low quality care. And the best example of that is when the patient is in a BUCA, fully insured plan, and they've got a PPO network that doesn't provide any guidance and information around not just the best doctors, but also the worst doctors.
Right.
I mean, okay, if you aren't going to tell me who the best ones are, at least spare me from the worst ones. I'll take my chances with average and above, but there's no help whatsoever. And the employer who chooses to put their employees in one of those PPO networks is forcing that employee to play Russian roulette with their life and their health every time they go and pick a surgeon or an oncologist or some other specialist who themselves then can affect that person's health and life. So I think the emphasis on quality is really, it's underemphasized. As much as you and I have talked about it, it's still underemphasized.
You know, it's true, Nelson, when one of the largest retailers in the US goes to their PPO and says, we want to drop the bottom 20 percentile out of our PPO directory, and that BUCA tells them, no, you can't do that. That will put us in violation of our contracts with providers, right? The deck is stacked against the patient and the employer who's paying for that patient's care. And so, you know, will patients still pick doctors that are in the bottom 20%? Yes. We're beginning to see people change their mindset and be more open and receptive to that. The other challenge is, and this is something that's really been hitting the media a lot lately, is look at the denial rates, right? This whole reactive cost control and doing it through denials. That's just utterly ridiculous. If you're doing medical utilization management correctly, and you're proactively looking at whether evidence-based clinical criteria are met or not, and when they're not, you're getting peer-to-peer involvement, you're getting redirection, you're asking the right questions. There is absolutely no reason for denial rates to be double digits, period, end of statement, right? And when people say, well, how are you going to save money if you don't deny care? By managing the utilization and hand-holding and guiding from the point of sickness. Stop reacting and start being proactive about helping patients to navigate the healthcare delivery side. The natural consequence of good, high-quality, evidence-based care will be cost-effective care. You know, and doctors who you said earlier, they should look in the mirror and look at the quality of care and the outcomes. Use evidence-based clinical criteria. You know, I give presentations a lot for medical students, for nursing students, and I always start out by saying, who in the room thinks that the practice of medicine, by the way, I've got a problem with the word practice of medicine, but that's another conversation for another day. Who thinks that it is just an art? And a few hands will go up. And who thinks it's just a science? And a few more hands will go up, and I'll go, so who thinks it's an art and a science? And every hand in the room goes up, and I go, with all due respect, you're wrong. What you're prescribing, the treatments you're delivering, there are enough evidence-based, double-blind, randomized, clinical controlled study trials published for 99% of the conditions you're ever going to treat that tell us what the gold standard of care is. Where do the benefits outweigh the risk? Where is the path to the cure, right? It's there. Why aren't you following it? Bedside manner, I'll give you that's an art. But what I tend to find is that the doctors who practice at the top of the evidence-based practice game, so to speak, don't always have great bedside manner, right? You ever met a neurosurgeon? No disrespect to neurosurgeon, but they don't always have the best bedside manner. The guys who have great bedside manner, sometimes I wonder if they haven't developed that as a coping mechanism because nobody sues somebody that they like. So even if the doctor makes a mistake, if you're like, oh my gosh, he's such a good doctor, he's so nice, he listened to all my questions, he did, I love that doctor, I just had bad luck. And that's one of the challenges that we as American healthcare consumers have to overcome. Being unhealthy is not just bad luck. It's, could be genetic, could be lifestyle, could be behavior, could be choices, could be bad quality of care, but there's nothing lucky or unlucky about the state of one's health and the recovery through it. That's a misnomer that's unique to the United States.
Well, you raise an issue that I think we're going to have to start hitting harder on, which is when a clinical decision is made, and that's dependent on often a second opinion, independent third party medical second opinion from a physician, not one of your nurses. They send it to a doctor who's a specialist in that area, a disinterested specialist. But more and more I hear from you and your team that the decisions you make are bound by this evidence-based medicine, these protocols that have been proven to be the most efficacious way to deal with this particular condition or medical situation. This isn't a choice. It shouldn't be a choice. This should be, if that's what the evidence says, right? This is how juries decide the fate, life and death of convicted murderers.
Right.
Let's look at the evidence and we'll make a decision based on the evidence. Now, do they always make the right decision? Sometimes, no, I understand that. But the ideal is we are looking at reliable, objective evidence, and we make decisions based off of that. Part of the challenge that you face at AIM, I know, is patients are looking for certainty. Right. I was just dealing with a friend of mine whose sister has bad cancer, and she just wants to know she's in good hands. Well, when you make it a determination, this doctor is those good hands, then I'm going to trust this doctor, even though the doctor might be wrong. And it's like, the doctor says I need this treatment. And the medical team at AIM goes, no, that's the wrong treatment. Or, you don't even have that kind of cancer. We got a second opinion. And the patient's going, I don't care what your doctor says, my doctor, right? And so you get into this kind of a pissing match between medical professionals. And that is a problem. But it goes to your earlier point about how familiar are patients with the fact that there is objective quality data on these providers. Let's move forward in terms of working within a health plan. I know not everybody who's listening is doing fully self-funded. When I say fully self-funded plans that they build, put together, assemble, and would say, okay, I want AIM to be my medical management vendor or provider. A lot still are working with fully insured plans, but they want to help those employers. Is there any advice or guidance you can provide an advisor who wants to help that fully insured plan because you can't move them from right now from that BUCA?
So I don't know who all is in the audience today. The best piece of advice that I could give those folks is to join the Next Gen Mastermind. And the reason I say that is because we as a solution partner to the Next Gen Mastermind make certain secret menu items available to our partners that are in that organization. So we have a program called the Bridge Program that's really designed to assist those groups with a couple of things. One being to begin to change the mindset of the patients proactively before you make that change from fully insured to self-funded, right? Get your people understanding some of these basic concepts, get them used to no longer washing their hands of and abdicating all responsibility to their healthcare providers, right? Because you're asking them, would you call the nurse? Would you engage with the nurse? Would you accept the second opinion? Will you, we have an open dialogue, we have an open mind. The other thing that it does is to help them to do some clinical underwriting. So, I mean, I know there are lots of ways. There's EOB scrubbers, there's artificial intelligence that's going out and scrubbing big data to do kind of quasi IMQs. Of course, there's the old form fire and IMQ process. All of those things still exist, but all of those need some sort of clinical validation to be accurate and to give the employer a level of comfort that they know and understand whatever risk they may be taking on as they become self-funded. But we don't offer that to the general public, Nelson. We only offer that to the mastermind.
All right. So for advisors who are doing self-funded with their clients, we have done, and I should tell everybody, by the way, let me say something, housekeeping real quick. If you've got questions that are coming to mind, don't wait until the end when we open it up for Q&A. Go ahead and make a note now. In fact, actually just hit the Q&A button here on Zoom and put your question in, and we will make our best effort to get to it. I don't want you, the problem is we forget questions that we had earlier because the topic moves on. And so be sure to put your questions in the Q&A box. Deb, I was going to say that you are faculty at the Next Gen Benefits Boot Camp that we run several times a year. In fact, we have one coming up in August, the last one for 2023, where we train these brokers and advisors on the Next Gen tool set, skill set, and mindset. It's a 3-day in-person training in Nashville. And Deb, you come in and you do the section on the healthcare ecosystem, the Next Gen healthcare ecosystem, and the provider network. We like to call them providers, not vendors, solution providers, and how to build that network. In boot camp, we talk about the BUCA black box, the fully insured BUCA black box that is so complex and so complicated that there's no possible way some mere broker could replicate that. And so what we do is we disassemble it, and by disassembling it, we demystify it, because it turns out there are not a lot of components in there. Oh, there's a lot of little stuff that really doesn't matter, but the big rocks: TPA, PBM, medical management, stop loss, some sort of repricing mechanism for claims, a PPO network in the case of the carriers, and then the marketing and the management of the plan, and that's it. So you are one of the big six, medical management. How should an advisor look at medical management as part of a Next Gen health plan that they're putting together for the client?
Depends on what they're trying to accomplish. And so I would tell you first, the reflection that they need to make is, am I a broker or am I a consultant? And if they're a consultant and they're truly understanding the goals and objectives that that group is trying to accomplish, and if they truly understand the culture of the group, then they can pick a medical management strategy that is going to make sense for accomplishing the goals and objectives of that particular group. So like here at AIM, we have basic, we have light, we have overlay plus, we have P3CM, we have P3CM platinum. We've got this whole long list of different products, all of which have different PEPY outcomes, all of which have different noise levels associated with them. So one of the other things we talk about in boot camp a lot, Nelson, is that PEPY noise teeter-totter, right? The faster you want your PEPY to go, the lower you want it to go, the more you need to expect noise, right? So, but a consultant's going to assess, we as nurses call it assess, plan, implement, evaluate. It's the nursing process that we use. If you're really assessing your client, you can decide, is carving out the medical management piece even a strategy that I want to do? Not every group should be carving out the medical management year one. There are instances in which you should just pick a TPA that already has the medical management bundled into it, because you need very low noise. You need everything just rubber stamped from the beginning. Now, I would tell you, you're better off to carve it out and put that together, like to use our basic product to accomplish that, than to go to a TPA that says our medical management's the only one. Because then when you are ready to take the next step, you're out of runway, right? And you have to change TPAs, and that means new ID cards and blah, blah, blah. Whereas if you pick independent solution partners for each of those, rebundle them together, and you want to take the next step in strategy, you don't necessarily have to blow everything up and start all over, which is less work for you as a consultant advisor, less work for HR, less disruption to the patient, right? So those are the kind of decisions that a consultant advisor has to make as they're going in and understanding the culture of the group, right? But too many times, what I think happens is that a broker goes in and sells a Cigna plan at half the price of Cigna. Someone that you and I both work with and respect and love a lot, Nelson, sent me a presentation, and one of the slides says, works exactly like your Blue Cross Blue Shield Alabama plan. It was on the slide for his presentation he's getting ready to give. And I'm like, no, stop, danger, danger, Will Robinson, come back, don't say that, because it doesn't work exactly. It feels like that to the patient, perhaps, but you can't get a BUCA plan at half the price of a BUCA plan. It doesn't exist, because there is a floor on PEPY. Unless nobody files a claim, there's going to be some claims costs incurred, even just for going for their annual physical exam, right? So I worry about people. And the other problem is I have groups that become customers, and it feels like what they want is a BUCA plan, right? The noise level of a BUCA plan, but the financial outcomes at 25% of the cost of the BUCA plan, and the quality of care to be 1,000% better than what they were getting under a BUCA plan, without telling any patient, no, you need to change doctors. I'm like, that world just doesn't exist. So it comes down to managing expectations for everybody involved in that process.
You're asking for different results by doing the same thing. It's just, that's Einstein's definition of insanity.
Right.
So and what you're alluding to is the crawl, walk, run, soar, fly model that we teach, where you've got to meet the employer where they are. There's an old saying, there is no zeal like that of the newly converted.
Yes.
And we see a lot of brokers who discover next gen, discover the awesome power that they have to help employers improve quality and control cost. But it's a lot like, the street corner preacher who wants to come up and convert you on the spot, and you're just not quite ready for that yet. You might be willing to have a conversation, but you're not ready to drop to your knees and turn your life over, right? So it's meeting them where they are. And this goes back to your point about being consultative. What are their goals? You've got a spectrum. Everything is on a spectrum. You've got that employer who he's running Google, and all he wants to know from the broker or consultant is, have you got any other benefits we can pay for our employees? Money's not an issue. He doesn't care. And then on the other end of that spectrum, you've got what I call hair on fire. That's the CEO who's about to have to shut his business down because he can't keep it going. One thing he could do is drop benefits, drop healthcare, but how many of his employees are going to stay? So he's got this terrible dilemma. he's ready to do anything. And you say, well, it's going to cause some noise. Yeah, what kind of noise is it going to cause when I drop healthcare, or when I riff everybody and pink slip them because I'm closing the business? It's a lot of noise too. I'll take the noise. And so it takes discretion on the part of the advisor. Where is this employer? You know, I had a conversation the other day with a CFO and finance director of a large auto dealership group in New York State. And they'd contacted me after they heard me speak at the SIA, Self-Insurance Institute of America conference, because they've had fully insured, a self-insured plan for 2 years. They haven't seen any improvement. And I had made the comment from the stage, most self-insured plans in America are underperforming and under-delivering. They're not living up to their promise. And they go, yeah, that's exactly right. What can we do about it? So we're having this conversation. And even as eager as they were to reduce cost, he said, I don't want to upset my HR director. I'm not interested in. So even he, who's ready for change, has his limits. And so you've got to suss that out and understand that, and then plan accordingly. So you've got a range of
Please tell me that you asked him what kind of education he's providing to his HR person about this topic, because that's another, I mean, it's a mistake, I think, to go to the C-suite and exclude HR. I think it's a mistake to go to HR and not have a conversation with the C-suite. That is one of the biggest disconnects that I see. And so it happens even like a broker doesn't get their account manager up to speed, right? Somebody is status quo and they come to Ascend and they get all excited and they go back and they put a next gen plan in, but they haven't brought any of their team along with them for the ride, right? So those challenges, identifying those at the outset, that's key, because he can educate his HR person, right? I hear that a lot, Nelson, from employers. Well, HR is not on board, or HR doesn't have the capacity. And I say, okay, if I'm saving you $5,000 for every employee that you have in your company, can you maybe hire somebody to help HR? Right? So, I mean, it's reframing that discussion with them.
Well, you've heard me say that HR professionals are the social workers of the corporate world. Their mindset is not financial, it's not strategic. They are people. They want to help those employees. And if you can explain to them that the current situation that they have been dealt, right, they didn't have any choice, is rotten,
Right.
and show them how their employees can get higher quality care and something we haven't even mentioned is the incentive for the employee to go to that high quality provider that AIM recommends isn't just their health and their life and lack of complications and healing faster and getting back to work faster. It's financial. We waive their out of pocket, which is for most employers somewhere between $6,000 and $9,000. In most cases, around $9,000. That's a lot of money for a working class individual. And that the HR director would love to know that her employees can get their health care for free. But if it's simply, I hired the broker, I picked the plan, and now you're telling me it's bad, I don't like you. Right. So it is an education process. It's showing that HR professional the respect that they deserve to bring them into the conversation. Now, we do advise, bring the C-suite into the conversation first, because you don't want HR sitting on the side, just shaking your head, being negative before you've had a chance to get the real decision makers for the company on board. Then you bring in HR, and either do it separately or in the group, bring HR around with the same logic and the same improvements for healthcare for their employees that won over the C-suite, along with the cost savings. So I think you're absolutely right on that. But I wanted you to talk about the differing levels of care that AIM can provide, because I think so many hear about what you call PC3 and Platinum, which is the most rigorous, most demanding, most noise inducing, because it requires employees to change the way that they utilize healthcare. But you've got these other options available that are much less, I guess, intrusive or noise inducing. Can you talk about those?
Yeah, absolutely. So I think of them as stepping stones, right? Or as a glide path to getting someone from fully insured to where they want to be, which is a next gen, total package kind of concept. We have a program called Basic. I think of it as Buka-esque, right? Very much follows the same staffing metrics and the same what does and does not require pre-cert. It does utilization review, not utilization management. It does only catastrophic case management. It doesn't do care management. So we call it the Basic program. It's somebody who's just coming out of fully insured and who doesn't really maybe totally get it and who wants very, very low noise, but wants resources available for those who want to opt in, right? So Basic is that program. Light is another program that we offer. I think of it as being kind of equivalent to when a TPA has a checkbox on their form for medical management, and you're letting the TPA either do or pick, subcontract out the medical management to their vendor. We'll get your catastrophic cases. We'll do some utilization review, maybe a little bit of utilization management. We'll include some maternity management kind of stuff, and maybe a 3 on a 0 to 10 noise scale. By the way, remember, the lower the noise, the higher the PEPY. We have a product called the overlay product, where we're not doing the pre-cert, but we're doing all the other pieces. And then, of course, P3CM. P3CM Platinum is where you have an incentive, where you're saying to the patient, if you call the nurse first, you follow the nurse's guidance and advice, your care becomes free, or if you're on an HSA, as low as is legally allowed under the law, right? So you're giving them a financial incentive and making it beneficial to them to engage and to follow the advice of the nurse. So there's stepping stones across that chasm to help employers, and some will go into a light program and stay there for a very long time because it's accomplishing what they want to accomplish. But that's kind of us in a nutshell.
Let's talk about in boot camp, we have a conversation with the brokers and advisors, you and I, about the 3 roles that a next gen advisor has to play. The broker role is simple. Brokers play the broker. That's all you have to do. But when you transition to a consultative advisor role and you are putting in next gen plans, which requires self-funding, not because self-funding is magical, it just simply allows you to take control of the plan and then manage the healthcare. If it's a BUCA plan, the BUCAs run the plan, whether it's fully insured or a administrative services only arrangement. And then you've got all of the cost containment strategies and all of the quality assurance strategies. So there are 3 roles. One is, to our earlier conversation just a moment ago, educator, educating the C-suite, educating HR, educating the employees. Now, it's not a role that you have to play all the time yourself. You can sometimes hire out educating the employees, but you are responsible for the education. Second is ringmaster, like the ringmaster at the circus, the guy, the long red coat, the top hat and the whip, and he's cracking the whip to get the attention of the different acts in the 3 rings. You've got to make sure the acts aren't bleeding over into the other ring. You make sure that they're working together when they're supposed to. But sometimes cracking the whip isn't enough, and you have to take off your top hat, take off the red coat, put on a striped shirt and a ball cap, get your whistle and your yellow flag, because you're now the referee. And Deb, this referee role is one that most brokers and advisors aren't comfortable with. I understand. It's not easy because it's contentious. It's conflict. By definition, it's conflict. no official running up to a play, blowing his whistle and throwing a yellow flag is making everybody on the field happy.
Right.
Half the people on the field are happy. The other half are very unhappy about that penalty that's been called. And there is a role for advisors to play in backing the health plan that they've put in place versus backing their employer client.
Absolutely.
And this is difficult. But when you put a provider in like an AIM, a subject matter expert, and then you challenge and question their decisions, first of all, that doesn't make sense. You say, well, I'm backing my employer, and your employer is using what objective data? What logic are they using? And they're not.
Right.
So I'm becoming more and more passionate about this role for the advisor to think of the plan as what they need to support. There's one advisor who, when AIM made a denial, called you up and said, why did you deny this? Explain. You said, well, the evidence-based medicine doesn't support it. Well, what's evidence-based medicine? Where does that come from? You made the mistake of telling them the organization that is the curator of all of this and then sort of the keeper of all of this data. And this advisor calls them to try to understand, what is this all about? Why is this the Holy Grail? Why is this the gospel? And finally came around and said, okay, I get it. You made the right decision. That's the kind of behavior we need to see from advisors. Because if not, what happens, Deb?
We all get fired and patients get hurt. And that's the worst part of the whole thing. And when that happens, you now have an employer and all of the folks who are a part of that employer who think that there is no solution and they just give up all hope. And that's the worst case scenario. One of the chapters of one of the books, I can't remember which chapter or which book, Nelson, but we've written 3 or 4 of them together now, talks about evidence-based medicine and the importance of it. I would encourage everybody to review that for sure. And it will answer some of those questions that particular partner had. But to your point, at the beginning of every sporting event in the locker room, the referees make a commitment that this is going to be a fair and unbiased game, right? And they know that the goals and objectives are to get through the game with as few injuries as possible, call the penalties that need to be called, be unbiased. They have a framework. Too many folks are jumping in to doing these kinds of plans without having that framework. And the successful advisors are the ones who hearken back to. Remember when we had the conversation about the goals and objectives that this plan was going to meet? And we talked about these pitfalls, and we talked about noise level, and we talked about risks that were involved with this, and so forth and so on. I had a meeting this morning with a large employer. They're in year 2 now of taking that first step. They're crawling, right? The crawl, walk, run, fly. They're crawling. And they still had questions about a vendor charging a % of savings. And I'm like, do you know how much that vendor saved you? Right? It's not us, not the medical management team. We don't charge that way. But this vendor had saved them hundreds of thousands of dollars on prescription drugs, and they couldn't understand why that vendor was getting paid a % of that savings. It just blows my mind. And I'm like, let's go back to the very first conversation that we had. Let's pull out that recording. Let's revisit that, right? Let's talk about the strategy that you put in place. And I think not enough people establish those goals and objectives, because we also in boot camp talk about the destination versus the transportation. You have to have the conversation about the destination. You also have to explain the transportation well enough that when these inevitable questions come up, or I didn't think you meant that, I think that employers have been lied to for so long that you could walk in under, swearing on your child's life that you're telling the whole gospel truth, and they would still think you're lying. It's the nature of the beast. So we have to be able to hearken back to, remember when we talked about, and remember when we anticipated these potential challenges and pitfalls.
You're absolutely right. And that's the advisor's job, to keep calling them back to, like, where you planted the flag. This is where we planted the flag, and here's why. So let's take the last few minutes for a couple of questions. One, Jen Walsh says, Deb, thank you for highlighting the importance of bringing account management along in the process. So many client service colleagues are overwhelmed unnecessarily. They're important advocates in helping this movement. Not a question, but Jen, I wanted to share your sentiment. Thank you. Let's see. Mike Murphy says, love your talk. How do you deal with the following issues? That some element of the medical literature is flawed, having been bought by big pharma, and there's an ongoing effort to quash outside opinions and a pattern of ignoring traditional holistic care management modalities.
So the best way I can answer that question, Mike, and thanks for asking it, because it's a really critical one clinically. There is one independent entity that employs thousands of physicians and gives them a framework for weighting their review of all of the medical literature that's out there. So I don't know if you guys have seen these statistics, but the day a doctor graduates from medical school, he's about 7 years behind in the current medical research. So it's really difficult for any practitioner, short of licensing some of these tools, which by the way can be a little costly. Although the good side of 70% of physician practices now being owned by health systems means that that health system most likely is already licensing that evidence-based criteria. The doctors just haven't tapped into it, which I would encourage any doctors who might be on this call, especially if you're owned by a health system, go ask your health system, do we license MCG and can I access it? Because the chances are the answer to that is yes. But there actually is a process, right? We don't, as nurses who are saying, whoa, not an MRI, do a CT scan instead, or vice versa. I use MRI and CT because CT has a lot of radiation with it. So if we're saying CT is better, there's some risk associated with that, right? But we don't want to be basing that on some study that was done on 3 blind white mice in Germany, right? We want it to be strong science. And so MCG, that entity, has physicians who read all of those studies, they assign weighting. It's really a complex mathematical algorithm to make sure that you get the best of the science. And typically you're looking for things that are peer reviewed, that they're published in credible medical journals, that they have been through some double-blind randomized clinical controlled study or trial, right? Even, we all know, even just FDA approval of something doesn't mean that it's strong, that it's safe, that it's widely used, that it's effective, right? So you really have to have an entity that's focused on the science.
I'm going to, it's a long question from Michael Salcido, I think. And it's basically a company that plans running okay. They're fully insured. They're not unhappy with the results, but they know they could be better. They know they could be more innovative and maybe get some better results. It would be great to provide them with a 2 to 3 year transition model where they could begin to incorporate innovative, high quality care programs that would enhance their current self-insured. Oh, I'm sorry, they've moved to self-insured or level funded plan. But can this model also work for clients' current fully insured program to transition, other than your bridge program, which is unfortunately limited to just the mastermind partners? There really isn't anything out there to speak of because, and it's expensive, relatively expensive, adds to the fixed cost of the plan or the premium in the case of a fully insured plan, and there's no financial advantage. unless you put in an HRA, buy up the deductible to a high deductible, and then let the insurance company become your stop loss carrier. And you're doing a $6,000 spec on each employee. And then you can do some, and that's part of the program, that the bridge program is part of the bridge program strategy. So yes, it's possible. Check with me or Deb on that, Michael. There are some strategies around that. All right, we are unfortunately out of time. Deb, thank you so much. You are always so incredibly informative. And I will tell everyone listening, Deb Alt thinks about this subject more than anybody I know, because not only is she living it, but she is sleeping it and eating it and breathing it as well. And I mean, I'm constantly getting texts from you with an article from here, an article from there, that helps keep me up to speed. But you're also finding these fairly obscure articles that are incredibly helpful. Deb, thank you. Thanks for all you do for the movement. Thank you for cluing me into the fact that we can control the cost of healthcare. And I'm sure we'll have you back at some point. But in the meantime, I'll see you next week at the third quarter Mastermind Summit here in Nashville. And everyone, thanks for joining us here in the Healthcare Lounge. We'll look forward to seeing you next month. Until then, take care. Godspeed.